Slap tears and instability of the shoulder, physical exam and imaging. My name is Mary Lloyd Ireland. I'm an orthopedic surgeon at the University of Kentucky. I do have a website that you can see here, marylloydireland.com. This presentation and others are on the website, also my publications and other areas of interest. I would welcome you to come visit the website. The University of Kentucky also has a YouTube channel. The labrum of the glenoid is an important structure for stability. You can think of this as being a deepener of the socket of the shoulder. The rim of the golf tee is deepened by the labrum. You can also think of the stability of the shoulder as being a circus seal whose nose is under the ball, or a contact lens covering the eyeball. These are good analogies to talk to patients about when you're dealing with a slap tear. A slap tear is like there's a little rip in the contact lens, so the eye is painful, or when you're throwing, if there's that unstable slap lesion, you'll have increased movement of the labrum in the cocking position of throwing and pain. 50% of slap lesions result in instability. The function of the biceps is to act as a stabilizer of the shoulder, acts as an adductor, that's the short head, a weak shoulder flexor, and humeral head depressor. Distally at the elbow, it acts as a supinator and flexor. It is important at the shoulder and the elbow in deceleration of the throwing arm. So you can see here in this diagram the different movements of the shoulder and what happens with the biceps as it sits in the bicipital groove, and the function it has on the proximal humerus or the humeral head. Proximal biceps instability and tears will be what we'll be talking about. Rarely do they occur in isolation. More commonly, the biceps is part of a spectrum of dysfunction involving the tendon and associated restraints, such as rotator cuff tears, subscapularis tears. We oftentimes will see a proximal biceps tendon problem. Proximal biceps tendonitis or overuse occurs in people who are manual laborers, swinging a hammer, doing repetitive type things. In factory workers, we can see an isolated biceps tendon problem that is distal to the attachment of the glenoid labrum. The labrum functions as a stabilizer, a bumper, an attachment for the biceps, as well as a shock absorber. So this is where that proximal biceps attaches. The biceps distally, and a lot of the named tests for that were more for a biceps tendon problem itself, and not necessarily one that was a slap where the biceps is connecting to the labrum anteriorly and posteriorly. The test for labrum tear that I like to use was described by Steve O'Brien. So there's pain with the arm in that position, and with the palm up, the pain goes away. If the pain is over the AC joint, the acromioclavicular joint, then it's an AC problem. If the pain is deep, it's a slap tear. And I do like using this. This correlates well to our arthroscopic findings. There's a peel back sign, which is more in external rotation, but in internal rotation maximally, if pain is deep, you're moving the glenoid labrum and the biceps and compressing it by the resistive testing, not allowing them to go upward, and then the pain has to improve or go away completely with a palm up position. This is what a slap lesion looks like on MRI scan with intra-articular gadolinium. You can see the gadolinium down here. This isn't too patulous a capsule Labrum is normal here, articular cartilage is normal, and you trace it up to here where the interarticular dye is between the labrum and the articular cartilage here. So this is a typical slap lesion, superior labrum anterior to posterior. The peelback sign at the time of surgery, this is an arthroscopy in the lateral decubitus position, looking from the back. That green cannula is out in the front. It's a Buford lesion. Subscapularis tendon is seen in the lower part. So this is an internal rotation. And now we go into external rotation. Internal rotation, which is the O'Brien's test position, now external rotation. And what you want to look at is how much the glenoid labrum peels back or comes off of the attachment on the glenoid because he has a slap tear. So this is the superior labrum posteriorly, superior labrum anteriorly. The middle glenohumeral ligament is here. This is an anatomic variant here with a Buford lesion. Subscap is out here in the front. Think about a test of the O'Brien's test or a maximum external rotation test in hyperabduction that you can do with a patient seated or supine, reproducing this arthroscopic view, and then it all makes sense why they have pain in the extremes of rotation with a slap tear. The thrower's shoulder involves 4 critical components. This is called internal impingement or impingement within the shoulder joint. External impingement or your classic impingement is impingement or compression in the subacromial space, not intra-articular as internal impingement. In thrower's shoulder, the 4 critical components are excessive horizontal extension, over-rotation, increased humeral translation, and internal rotation deficit or GERD, glenohumeral internal rotation deficit. This is what internal impingement looks like on the abduction external rotated view. So this is the view, the Aber view, if you will, abducted externally rotated humeral head. And that is the partial rotator cuff tear. Bennett lesion or thrower's exostosis is shown here very well on the CT scan on the right as well as on the MRI scan on the left. This is a periosteal lesion common in throwers. You can see this on the plain films. This goes along with the thrower's GERD, tightness back here of the capsule, periosteal reaction, oftentimes in association with a slap tear or instability in an overhead thrower. Labral tears can occur with leakage of the fluid intraarticularly into a cyst that forms. This is a labral tear with a paralabral cyst. This is actually one that's relatively superior and posterior. So the labral tear occurs first, and then the cyst occurs. If we take care of the labrum and repair it intraarticularly, a decompression with a needle of the cyst or debridement of the cyst will result in the cyst going away because we fixed the intraarticular problem. Much like a radial tear of the lateral meniscus with localized cyst, fix the meniscus, remove part of the meniscus, and the cyst goes away. So the cyst reflects that there's something going on intraarticular. Cysts can occur at different levels. What the nerves that get compressed from the cyst are the suprascapular notch as the suprascapular nerve comes through. If it's entrapped or there's pressure in that area, this causes weakness of both the supraspinatus and the infraspinatus. If it's further distal in the spinal glenoid notch, compression causes weakness of the infraspinatus only. So this is a good example of the different levels of the notch, the suprascapular notch and the spinal glenoid notch. Typically by fixing the labrum intra-articularly, the cyst will go away. It can cause significant compression, and if there is neurologic involvement, open exploration or arthroscopic exploration may be necessary. From labrum tears or slap tears and throwers, we're going to shift gears and talk about instability of the shoulder. The arm position dictates which of the glenohumeral ligaments is the main stabilizer or restraint, primary or secondary. Typically, your instability occurs with the arm 90 degrees and externally rotated behind the plane of the scapula, and the primary restraint is the inferior anterior glenohumeral ligament. At 45 degrees, it's the middle, and at 0, it's the superior and the middle. However, with instability, a secondary restraint at 90 degrees is the middle glenohumeral posterior ligament, posterior capsule. So anterior, inferior, posterior, inferior, a hammock is created, and when we do instability surgery for anterior instability, we want to recreate that hammock, typically putting it back to the glenoid. So at 90 degrees is when the anterior inferior glenohumeral ligament is the primary restraint. Stability testing. This is the supine test. You can grab the proximal humerus, as I'm doing here. I find it easier to get closer to the humeral head so I can get a better feel for any labral click and the direction that the humeral head is going in. So I'm anteriorly luxing him and then reducing him. So I put my long finger under the deltoid posteriorly and then basically rock the humeral head forward and backward. And a reduction of an anterior subluxation, they can say that reproduces the pain. Sometimes you'll get a labral click. So this is an anterior subluxation reduction test. Check for rotation. You can axially load them. Now I'm pushing him out the back. So pushing him out the back would be a posterior instability test with sometime a labral click. Instability of the shoulder is quite common. Labral tears can occur being avulsed from the glenoid, more commonly anterior than posterior. Sometimes we'll see degenerative labral tears in somebody that's a weightlifter. There can also be capsular insufficiency, as in a multi-directional instability where the capsule is just stretched out. The best labrum to fix is an acute dislocation where there's a bony Bankart lesion. We can put that back and they're very stable. However, it still takes about 6 months to return to a contact sport, and that's the earliest. When we think about the exam, we want to define the pathologic direction. Anterior is the classic Bankart lesion, labral avulsion, anterior inferior quadrant. Shoulder can also come out the back. The tissue isn't quite as good there, and hence on the MRI scan we might not see that classic labral detachment. You can also have a multi-directional instability where the shoulder goes any which way but loose, and the labrum may indeed be normal. The treatment of instability, if there's acute dislocation with a bony Bankart, this should be arthroscopically addressed and usually can be arthroscopically fixed with a labral repair. Sometimes we have to do an open capsular repair or a shift. In chronic situations and failed anterior surgery, bony procedures are necessary. We should try to diagnose early shoulder instability, particularly in contact athletes, so this can be addressed with soft tissue procedures and not bony procedures. Immobilization in these young athletes We do immobilize them 2 to 4 weeks. MR can be helpful in that if something is knocked off, we should address that early on and not allow shoulders to be dislocated numerous times. Football athletes, at least in Kentucky, still enjoy having their coach or another player put their shoulders back in, and oftentimes come in with 50 dislocations before they're seen and fixed, stabilized. Surgery is arthroscopic, but if it is a chronic situation, open surgery addressing the capsule and sometime requiring bony transfers are necessary. Get them early and fix them. Keep them out of the game long enough so that they have a stable shoulder and will do well for the rest of their lives. Surgical stabilization, the different types of Bankart lesions, and really what we're trying to do is to put that golf tee lip back on, glue it on, sew it on, screw it on. The other analogy of thinking about instability is the bumper that keeps the airplane or the car from rolling forward or backwards. So what we're doing is recreating the bumper effect. And this bony Bankart, again, if you have a piece of bone here and a nice big labrum, that is a good feeling to put that back down. The classic Bankart is the ruptured periosteum. If it goes up higher, there's a Perthes lesion, ruptured periosteum here. So this is the bony Bankart. If that fragment is small or it's been a chronic instability, sometimes we take that little piece out and make sure that we've reestablished the labrum back to the lip of the glenoid, not down on the neck of the glenoid, but back to recreate that bumper effect or recreate the T. So if you've got somebody that's come out numerous times, that tissue isn't as good and we can't as successfully repair it back because the tissue gets to be degenerative and doesn't hold sutures as well as it does in a more acute situation. What about the radiographs? Hill-Sachs lesion is a posterolateral humeral head compression fracture that occurs when the shoulder is dislocated. This is a striker view. The arm is in external rotation. You can see here where there's this radiolucency consistent with anterior instability and Hill-Sachs lesion. This is the view in internal rotation. You can't see that quite as well. This is the axillary lateral view. This is a great view for looking at the status of the glenoid. Always look at the coracoid. That means that's in the front. So this is anterior, this is posterior. The humeral head here looks good, and we do not see a bony Bankart lesion. In other words, the T looks normal. West Point view was described to better see that Hill-Sachs lesion of the posterolateral humeral head. This is the way this view is done. You can also do variations of rotation of the humerus and see a Hill-Sachs lesion. Hill-Sachs lesion is also well seen on MRI scan with edema of the posterolateral humeral head. CT scan is necessary to assess the size of the Hill-Sachs lesion if it is a chronic situation, and the concern is how big that Hill-Sachs lesion is. That would be an engaging lesion and may need to be addressed with more aggressive open surgery and bony transfers. The axial view can be done in several different ways. This is a view on the top with the arm externally rotated, and the view on the bottom is the arm internally rotated. The internal rotation view may show a little bit better the Hill-Sachs lesion, but you also want to look for that Bankart lesion out in the front. So again, coracoid is here, and that's anterior. The glenoid is here. This is this bony Bankart, indicating that the humeral head came out the front, and the indentation or the fracture is going to be now here. So the humeral head was here. This is actually the greater tuberosity, and that's in the front of the shoulder in this view in internal rotation. So in external rotation, we don't really see the bony Bankart. In internal rotation, we do, but this indicates that when the dislocation happened, which was a recurrent dislocation with the arm externally rotated, comes forward, and then you get this impaction indentation fracture described by Hill-Sachs. This is what the Bankart fragments looked like. The anterior lip of the glenoid, the bone itself, looked like this, and this was from a chronic anterior instability. So look for the Bankart lesion on the axial view. What about posterior instability test? This is a prone test where I'm pushing up on his humeral head and palpating the posterior humerus. If you get a click or an apprehension, that indicates the direction of instability is posterior. In this position with arm and external rotation, I'm stabilizing the scapula, and he would not like it if he had anterior instability. So think about doing prone tests as well. Seated tests are very nice to determine an asymmetry in instability, pulling down, thinking about inferior luxation of the humeral head, and then I've got my hand on his humerus, stabilizing the acromion and the clavicle, rocking back and forth, asking him if that reproduces his pain. Going into external rotation, that would mean anterior instability like that. Does that recreate his pain? In an apprehension for anterior instability, backward flexion, external rotation. Again, stabilizing the acromion and the clavicle. Now I'm looking for clicks, axially loading this, almost like a McMurray's test of the shoulder, indicative of a slap lesion or a labral lesion when I'm cranking on him and axially loading him like that. Oftentimes the patient can demonstrate posterior instability. This is going into internal rotation adduction. If there's a clunk and that reproduces their symptoms, then that would be a multi-directional instability. So ask the patient to move their arm in the position that makes them uncomfortable, and they oftentimes, particularly with the posterior instability situation, they can reproduce that posterior instability. In that case of multi-directional laxity or instability, if they're coming to see you, that laxity has become instability. If it's voluntary, that's a prescription for rehab and not for surgery. This is an individual who I did not operate on. Someone operated on her right side with an open capsulorrhaphy. She is a multi-directional instability, an Ehlers-Danlos type Marfanian habitus. So this is her shoulder that bothers her the most. Inferior dislocation there. Her other shoulder that doesn't have a scar on it has pretty much an equal exam. So inferior instability. See the acromion there, and we pull down and she's inferiorly unstable. She doesn't want to look up. She's in a forward head position. Her shoulders are sitting anterior. So when we ask her to move her shoulders, in that position would be coming out the front. So her operated side not only is not stable, it bothers her more than her non-operative side. So don't operate on these individuals, treat them with rehab. We treated her in a figure of 8 harness and told her to look up. You can see how she can voluntarily anterior inferiorly sublux her shoulder and then put it back in place. It's out here, it's reduced here, just from manipulating really her scapula around and getting the proximal part back in the right spot in relation to the humerus. This is an example of a voluntary posterior dislocator, doing this push-up. You can do it at different arm positions. So he's got scapular symmetry. But what he can do going into internal rotation adduction is posteriorly sublux his shoulder, and then it goes back in place. So the clunk that you see can be confusing, but if somebody can do that, they're coming out the back. Stabilizing the acromion and the clavicle, pulling it down, and then again just rocking him out the back and then out the front. He has a habitual posterior instability. Try to get him to sit up straight, keep his scapula in a better position, But think about what you're doing with these exams. The seated exam, coming out the back and then jumping back in, coming out the back and jumping back in. He was treated with scapular stabilization, external rotation of the shoulder, strengthening, and we suggested that he not try to pop his shoulders out. His strength was good. And this was his side that wasn't bothering him. And you can see how the scapula wings. Obviously the scapula is connected to the glenoid, so it wings as the shoulder comes in and out of place. This is a cheerleader dance athlete. So looking at her from the front, you can't tell maybe what's going on, but she's posteriorly subluxing both of her shoulders. Party trick. So look at her scapula. So an internal rotation, adduction of the shoulder. Shoulders are out, and then they go back in place. She can do them bilaterally in a rhythmic way. Treatment is by rehab, making sure she's not on the base of the pyramid because she'll drop everybody above her. Scapular stabilization, and no operation. But ask the individual to demonstrate what their complaint is, and oftentimes they can more easily posteriorly sublux their shoulder than you're able to demonstrate with your exam. You can have them do it up high, up low. This is a right-hand dominant discus thrower. Through the discus, felt a pop, had pain and inability to move her arm. She went to the emergency room. Axial views showed the humeral head to be posteriorly dislocated on the axillary lateral view. The direction of this posterior dislocation is still missed in some emergency rooms. The arm is fixed in external rotation, and internal rotation is not possible until the shoulder is reduced. This is her posteriorly dislocated shoulder. Again, you can see this axial view. This is the coracoid. This is the glenoid, the acromion, and you can see how nobody's home in the glenoid, and her shoulder is posteriorly dislocated. Reduction was done. This is what her MRI scan looked like. So here's the coracoid. Here's the anterior labrum and bone. Here's the posterior or reverse bony Bankart. And the labrum was avulsed because of her age and the fact that the labrum was knocked off. Posterior instability, reconstruction, repair was done arthroscopically. We suggested she not continue to be a track and field athlete. This is what her exam under anesthesia was like. You can see she has significant rotation, almost 360 degrees around. Here's her exam. So posterior instability, axial loading goes out the back, is reduced, out the back, reduced. Again, you can grab her humeral head when they're under anesthesia. Is a great time to examine them. She did not have any anterior instability. It was all posterior. And posterior capsulorrhaphy labral repair was done. Successful outcome. So in conclusion, don't order a test if you can't read it. If you can't read the MRI scan, a better test to do would be a consultation with somebody who knows shoulders. Communicate with the radiologist at your imaging center. A bad scan is worse than no scan. In Kentucky, we have many MRI scanners. Shoulder scans are notoriously bad if ordered by someone who is unable to examine a shoulder. Sometimes the MRI report just doesn't help. This one is actually in Chinese, and this makes a little more sense to me sometimes than the X-ray readings of the shoulder by English-speaking radiologists. There are some things that don't translate into Chinese. Dr. Lockman, this was an MR of a knee, doesn't have symbols, and CT and MRI scan. So communicate with your radiologist, and hopefully he will communicate better in the report. all MRI scans of the shoulder have some abnormality. Oftentimes it's a acromial slope or something like that, but I've never seen a normal MRI scan reading of a shoulder. So if you want to find something wrong with somebody's shoulder, do an MRI scan, and then you have to talk them off the MR cliff. They oftentimes think they're going to have a significant problem if they don't have surgery. Listen, look, examine, then listen, look, examine again. This cartoon, I'll have to do some x-rays to be sure, but I'm guessing you dislocated your shoulder. Hee hee.